I'll be talking about COVID-19, looking at the health and gender lens. And my talk is based on our work from LVCT Health and just experiences we've had in Kenya. And as you've heard, LVCT is a large NGO and we focus on the needs of the vulnerable and marginalized. And we have been involved in HIV, sexual reproductive health, gender-based violence programming. And so we fit right into COVID when it came. And so I'll be sharing some of the things that what we have learned or what we've seen as we have been programming and since COVID started in Kenya. And so that slide talks about basically COVID in Kenya, where the first case was diagnosed in March last year. So we've been, and from that point, we had a lot of measures put in place to really minimize the risk of spreading the infection to others. And this was set up by government, and the response has been led by government across the country. We're currently experiencing our third wave, as you can see there, so it keeps getting progressively worse. The numbers came down, that's just and something to talk about just testing. So in Nairobi, we had our third wave, it has reduced, but now we have a high number of infections in the western part of the country. So we keep having it that way, it moves from Nairobi to the other sections. And so far we have 179,000 confirmed cases with 3,500 deaths. But the caveat here is these are only those that are confirmed by testing. So we expect that the actual numbers could be 5 times more than this or way more. So some of the measures that were put in place were like a national curfew, which we have had for the last 1 year. So we have a nationwide curfew of 10 p.m. to 4 a.m. And depending on, at the peak of the wave, it comes down to say 8 p.m. or 7 p.m. And we also have restriction of movement in and out of different counties or districts. So like now we have the western part of Kenya, movement is restricted in and out of there. Schools were closed for 9 months, which had a lot of bearing on some of the effects that we saw. Bars and restaurants were closed, but these, every time we have a peak, they close, then they reopen. So they are open now, at least in Nairobi. Public transport was expected to transport half the passengers to minimize the risk. And this increased the costs, so just double the cost of transport because the public transportation is private. So people have to pay for those services. We have a compulsory mask mandate in the country, and sometimes enforcement has been part of the challenge, depending on how the police will come and bear down on people if they're not wearing masks or arrest them. So my talk is really focused on the effect of this on the vulnerable and marginalized populations that LVCT works with and what we've seen across. So the businesses were severely affected. Hospitality industry, just like the rest of the world, school business and those who support that, and small businesses. But also we know large businesses were affected, and this resulted in severe loss of income, and loss of food and shelter was very serious, and we don't have social support structures that can be able to sustain people. So there were a few measures by government to provide stipends, but those were for a limited number of people, and we don't have a registry to know who's vulnerable. Health services were quite affected. We had, initially there was a lot of panic, even by health workers and health facilities. So when a health worker would test positive, the whole facility would be closed, limiting access for other people. And this was particularly bad for women and children, who are the ones who frequent facilities the most. So like what were considered not essential, like the sexual reproductive health clinics would be closed, the family planning clinics or antenatal care sometimes would be closed. Some maternity wards were turned into isolation wards, and so women had to go much further to find places to deliver. Patients were limited in accessing facilities to avoid crowding, and there was just general lack of the personal protective equipment. So the other things was stigma and discrimination. That photo you can see at the top there is how when the epidemic began, when anybody was tested positive, the people dressed in white would go fetch them from the house. It was very dramatic and take them to the hospital. So this created a lot of fear and stigma. There are myths and misconceptions that persist up to now, and people are in denial. They don't want to be branded as having COVID. Gender-based violence has been talked about in so many places, and this was really increased. We had sexual violence. People were locked in. A girl trying to go to the toilet outside in the slum at night were raped, and we know of intimate partner violence and violence against children. We've also seen an increase in pregnancies and HIV and STIs, not to mention the mental health effects that we're still monitoring up to now. At the health system level, we've managed to do almost 2 million tests, but this is a drop in the ocean. Testing is very expensive, so you have to pay for it, meaning a lot of people were denied access to these services. And some services stopped, like testing for HIV, we had lack of oxygen and drugs. So from that perspective, what we have learned and the lessons that I'm sharing here is that we have to have what I would take and share back to policymakers if we had to do this again is use localized responses that involve communities. If you're saying that people have to wear masks or must wash their hands or socially distance, what should you do in a slum setting? So the communities there can give a lot of input. And we have to consider the needs of the vulnerable when making decisions like lockdowns, like transport being limited, people being unable to move around. We have to look at what that means and tackle stigma and myths and misconceptions right from the beginning to avoid what we've seen where up to now there's heavy stigma around COVID. We need data continuously on who's vulnerable and who's marginalized so that when we're making interventions, we address those. So like there's a study we're doing right now to see who is disabled, the elderly, or the child-headed homes, the orphans, that can help government to then be able to inform future interventions. And we have to invest in strengthening their health system so that they can deal with this epidemic and future epidemics, remembering that health is for all and not just for some. So I can't finish without talking about COVID vaccine, and this is really what is, for us, troubling. We are basically running out of COVID vaccines. And as you can see from the graph on the right and what I've shaded in red, only less than 1% of Kenyans are vaccinated. And Kenya as a country has the capacity to scale up its vaccine coverage. We have systems across the country that we usually use and have been shown to work even now. So about 1 million people have got the first dose, and now we're struggling and running out of doses for the second dose. And you can see on the left from today's headline, poor countries have run out of vaccines and we're not able to access any more. So with few coming in, like today, we're able to get some from Denmark because they were not using AstraZeneca. So we've seen that these are huge gaps that have come through, and the inequality is really felt when we're seeing that countries like the US, for example, are almost vaccinating everyone, yet we've been unable to reach our health workers or the vulnerable, who in total would make less than 3 million or 4 million individuals. So just to add some quotes from a high-level people who are talking about this, we need to remember that the pandemic will not end until everybody is really reached and protected. Otherwise, we'll keep getting these waves that are coming through. So we have to have global accountability for COVID vaccine to ensure that all health workers and the marginalized and elderly are reached. And as we continue with the other measures, we have to avoid hoarding of vaccines or delaying up to the point when they expire, which is what we're seeing. And that aspect of allowing vaccine manufacturing in low and middle income countries. So we're happy today to see that there's some progress. South Africa is planning to do this manufacturing, but it is disturbing for us to see how much it's a struggle to even get access or the rights to do that. And so we hope that developed countries can see the value in investing in the systems in low and middle income countries as opposed to treating this like charity. Thank you.